Hi there, my name's Arthur Cummings and I'm going to be guiding you through the consent video for custom lens replacement. Now, in your journey thus far, you've been assessed at the clinic and I have validated and verified that your best procedure for you, considering all the facts, is a custom lens replacement. And you should have received by now a DocuSign digital consent or perhaps a hard copy consent. And this video is designed to be an assist in the process of understanding the consent form. It remains up to you to ask me any questions you like prior to the surgery to ensure that you are properly informed. But the idea behind this video is to make sure you're as informed as well as we possibly can. The first thing to bear in mind is that there are alternative treatments, both surgical and non-surgical. So you know very well that you can wear glasses or contact lenses instead of having surgery. So surgery is elective. It's not something that you have to do. It's something you'd like to do for different reasons: lifestyle, sports, convenience, career. There are two types of refractive surgery. One is on the cornea, and that includes LASIK, LASEK, PRK, transepithelial PRK, Streamlight, and they use excimer lasers to change the shape of your cornea. And your cornea is the clear window in the front of your eye that focuses light. And once you've had the treatment done, light is now correctly focused so that you can see without the use of glasses. And then you also get a series of procedures that are inside the eye. There's one where you add a lens, so it's almost like having a contact lens inside your eye, and that's called ICL. Or there's one where you replace the lens, and that's called a custom lens replacement. Irrespective of what procedure you're having, they're designed to improve the vision you have without glasses.
Vision correction procedures do not cause, but also cannot prevent you from developing other eye conditions, for example, glaucoma, cataracts, or macular degeneration. These conditions may develop as you age or long after the procedure, so it's important to undergo regular eye checkups every 2 years so that any new eye condition can be detected early. Vision correction procedures do not cause cataracts. A cataract develops in the natural lens of the eye and causes the lens to become cloudy, reducing your vision. And cataracts occur as a normal part of aging and may still occur after you undergo a vision correction procedure. Presbyopia is the condition that develops as we age, where the eye loses its ability to focus up near or up close, and glasses are then required for close work tasks such as reading, using a mobile phone, and putting on makeup. And this process typically begins at around 40 years of age. And vision correction procedures do not cause, but cannot prevent presbyopia unless we specifically target one eye for distance and one eye for reading.
So during CLR, the natural lens of the eye is removed and an artificial lens called an IOL is inserted in its place. The IOL inserted is calculated to improve your vision, and CLR is surgically identical to cataract surgery. It's just more precise. And cataract surgery is performed to remove a natural lens that has become cloudy, where CLR is performed to remove a healthy natural lens to improve the visual performance and reduce or remove the need for glasses. And CLR is a voluntary elective procedure. There's no medical necessity or urgency unless you have narrow angles. The medical team will inform you if this is the case. The way the procedure works is a very small incision, normally around about 2.4 millimeters, is made in the front part of the eye, and this is to allow us to remove the lens and place the new lens inside the eye. The wound is so small that it closes without the use of stitches. We use stitches 1 in 100 times maybe. And after your natural lens is removed, we need to place an IOL. In rare cases, if complications occur at the time of surgery, it may not be possible to implant the preferred IOL or any IOL at all at that surgery session. And a secondary procedure may allow for implantation of another type of IOL at a later date. A temporary clear plastic shield will be placed over the eye to protect it during the immediate post-operative period. After the surgery, your eye will need to be examined either the following day or 1 or 2 weeks post-operatively. Your team will tell you when they'd like to see you again. You may see some improvement in your vision as early as the first day, but normally it takes a few weeks to stabilize, and you will return to the clinic for additional post-operative exams as instructed by your medical team. As far as the risks and complications go, one that you need to consider is the risk of anesthetic. Now we know it's very low, but you have two choices. The one is surgery performed under local or topical anesthesia, that means drops only with some sedation, versus a general anesthesia where you are fast asleep and know nothing about the procedure. And this is something we will discuss with you on the day of surgery if you haven't made your mind up yet. Mild or severe infection is possible. This can normally be treated with antibiotics and does not lead to any permanent visual loss. Severe infections, even if treated with antibiotics, could lead to permanent scarring and loss of vision that may require further surgery, or if severe, corneal transplantation, blindness, or even loss of the eye. So severe infections resulting in blindness, which would be 1 in 1,000 cases on a global basis, or loss of the eye, 1 in 10,000, is extremely rare. Now, the incidence of endophthalmitis in Ireland is 1 in 5,000 cases, so 5 times better than the global number of 1 in 1,000. And this is because at the end of surgery, for the last 15 years, we've been putting an antibiotic inside the eye at the end of surgery, and that really protects us from infection. You will also additionally use antibiotic drops post-operatively to reduce the risk of developing an infection. Endophthalmitis is very rare, but it's obviously very serious. And it may impact even not only how you see afterwards, but also how you may look afterwards if you lose sight in one eye or lose an eye. Inflammation is something we don't see commonly because we use anti-inflammatory drops before the time to address inflammation, and we do it post-operatively too. And it's quite a unique individual response. But generally speaking, it's not a problem for lens surgery. Retinal detachment can occur post-operatively. This is the separation of the retina from its adhesion at the back of the eye, and it results from a tear in the retina and could lead to vision loss. And patients with moderate to high levels of short-sightedness have a higher risk of retinal detachment when compared to the general population, and the risk level may be increased with complicated customized lens replacement surgery, where the posterior capsule is torn. Today we have a calculator that can give us the exact risk for you, and this is something we'll take into account when we make the decision whether this is your best choice or not. In your case, we have deemed the risk of retinal detachment to be very low, and hence this remains your best choice. Corneal edema or corneal swelling may develop during the surgery, and it may continue for a while after, from ultrasound damage to the inner lining of the cornea. And the loss of these cells from the inner lining may result in this hazy and opaque appearance of the cornea, which could reduce vision, but is uncommon today. As far as glare goes, there may be increased sensitivity to light or night glare, given how clear these IOLs are. There may be a starbursting or halo effect around lights at night, and the risk of this side effect may be related to the size of the pupil, and patients with larger pupils may be at increased risk. And then patients who have a full range of focus lens inserted, and those opting for blended vision have an increased risk of glare that we'll discuss in more detail. There may be some glare at night in dimly illuminated situations for a while after the procedure. It tends to take longer for the night vision to recover, and a guideline is 1 month per diopter for the glare to diminish back to normal. Everyone has some level of glare. So if you're a -3, it might take 3 months before it's cleared completely. If you're a -6, it may take 6 months. If you're a -8, it doesn't take 8 months. It'll never take longer than 6 months to get to its best. There's a particular condition though with blended vision that I want to explain to you here. The distance eye is here on the left, and the reading eye is on the right. Now, when you do the treatment on the distance eye, light coming in from a distance is coming in parallel and is now focused perfectly on the retina. There's no glare, no halos. On the reading eye, however, light is focused more acutely to allow you to read, and this leads to this blur circle on the retina. This is something which you can correct with glasses for driving at night. 7% of people get these at the 6-week visit, but once we see these people again at the 6-month visit, only 1 out of the 7 is using it. So if you think about that, 1 in 100 people would wear glasses to drive at night. The rest are freer glasses, so glare is something that typically reduces. Additionally, today we can treat glare with different ablation profiles like wavefront guided or topography guided. So there are ways to in fact even reduce the glare that you currently have before having surgery. Refractive surprise is where we are targeting a certain outcome, for argument's sake 0, which means you need no glasses for distance, but we don't achieve the result we intended, and this will explain why. Biometry is the method used to calculate the IOL power to be inserted, and it's very accurate in the majority of patients, but the final result may be different from what was planned. So irrespective of the precision and accuracy of our measurement tools and the calculations, the one part that's not precise and accurate is the healing response. So as the eye heals, the IOL can shift very slightly forward or backwards, and that changes the power of the lens. And the amount of this shift is not the same in everyone, and it may cause a different vision than predicted, meaning glasses are required after surgery. Now, patients who've had high prescriptions or previous refractive surgeries may have a greater risk of achieving the exact target. If you have a refractive surprise or have a residual prescription after your surgery, the medical team will advise you if you are suitable for a laser refractive procedure to correct this residual prescription. There's no additional cost for the surgery if it is required to fine-tune the prescription. Now, your natural lens is typically about 4.5 millimeters thick. The IOL that's going to replace the natural lens is typically less than a millimeter thick. So you can see that the new lens is 5 times thinner than the old lens. So where exactly it's going to land inside the eye is a healing process outside your and my power. A posterior capsular tear with or without vitreous loss. It's possible that during the surgery, a little tear may occur at the back of the capsular bag that supports the lens. And this may disturb the gel or the vitreous in the back of the eye, and further surgery called vitrectomy may be required to remove the disturbed gel. And the removed gel is replaced naturally by the fluid from the front of the eye. If a posterior capsular tear occurs, the bag which holds the lens will not be stable, and an IOL may have to be placed in the anterior, the front part of the eye, or in the sulcus, which is in front of the capsular bag. And sometimes it means we can't put in the lens that we had planned on putting in. If there is a posterior capsular tear, this can be with or without vitreous loss. Vitreous is the gel in the back of the eye, and if there's a tear, some of this can go into the front of the eye through the tear. This increases the risk of a retinal detachment. So there's the lens, a small little tear occurs in the back thanks to the sound waves that are breaking up the lens, and this increases the risk of a retinal detachment. This is very uncommon, but you can get something called decentration of the IOL. So even though the IOL is placed in the right position, it may move slightly and it may have to be removed surgically or exchanged for a different lens implant. Custom lens replacement surgery does not impact the state of the eyelids, but the steroid eye drops that are used post-operatively may cause the eyelids to droop. Once the course of steroid eye drops has been completed, the lids will return to their pre-operative position. The visual result is typically very good, but an overcorrection or undercorrection could occur, causing long-sightedness, short-sightedness, or increased astigmatism. And this could either be treatable with glasses or contact lenses or additional surgery. Now, most people have done this surgery because they don't want to wear glasses anymore, so typically it is done by further laser vision correction in the form of PRK to correct that small residual error. And you'll have the opportunity to discuss potential complications of any additional surgery with the medical team if additional surgery is required. And the odds of requiring an enhancement with laser are in the 10 to 15% range. We don't charge for that laser, so we can guarantee you we're doing our level best at the lens calculation to ensure you don't need laser afterwards. But as I said before, we cannot control the healing of that capsular bag and where the lens finally comes to rest. Cystoid macular edema or swelling at the back of the eye and the macula, that can occur after surgery. It used to be quite common many years ago, but for the last 20 years has been a lot less common since we pre-treat people prior to the surgery with anti-inflammatory drops. This is by far the most common occurrence after cataract or lens surgery. And it's so common that it's not really a complication, it's just a side effect. So this happens when cells within that capsule lose their transparency, causing some blurred vision. And that can occur months, even years after the surgery. And it's corrected by a procedure called YAG laser. And the YAG laser takes 60 seconds. It's painless. It's covered by health insurance most times. If you don't have health insurance, there's no charge for it. And this makes a little opening in the back of the capsule to allow light to pass through unobstructed. And the odds of requiring YAG are normally around about 5% over your lifetime following the procedure. And you only ever require it once. Now, if during surgery there's a tear in the back of the capsule, it's possible that some parts of the lens can fall through this capsule into the back of the gel. And this may result in floaters after surgery, and in some cases would require further surgery to remove these fragments. Dry eye disease. So mostly occurs as a result of suddenly not having the protective effect of glasses or contact lenses anymore, and the reduced corneal sensitivity for some weeks to months after the procedure. And typically it resolves with the use of lubricating drops or artificial tears, and by 6 weeks post-operatively, the majority of patients no longer need to use these drops. Dry eye disease tends to affect certain patient groups more readily. For example, women around the age of menopause, contact lens wearers, long-sighted patients, and those who had dry eye disease preoperatively. You will know from your exam in the clinic whether you're at risk of this, and you can rest assured we never proceed with the procedure if your eyes are not in a satisfactory condition in terms of the ocular surface. Dry eye disease may last longer than 6 weeks post-operatively, or very infrequently may be a permanent condition. These are cases we've read about in the literature, but have not seen personally. Recent studies, however, are suggesting that the post-operative dry eye disease conditions are not dry eye disease, but rather the corneal nerves responding to the surgery. All of the biomarkers we currently have today for dry eye are negative in this post-operative phase. So STODS provides a much better understanding of, in fact, what is going on and what we've referred to as dry eye disease in the past. STODS stands for Surgical Temporary Ocular Discomfort Syndrome. So it's induced by the surgery, it's of temporary nature, it always clears, and it's uncomfortable and feels like dry eye. It's transient and recovers fully, sometimes taking up to 6 months. Glint is a phenomenon whereby an observer looking at you may see a glint or a reflected light from the IOL, from your pupil, when light catches the eye in a certain way. It's not possible to predict who may get glint post-operatively. It's relatively uncommon, with most experts agreeing that it may be prevalent in maybe 5% of eyes. So you've now heard about the medical risks, and up until that point, this is where you are a patient. But from now on, you become a consumer, because we need to decide what lens is going to be best for you. So the IOL choice will strongly influence the visual result. So it's important that you consider all of the options and where you spend most of your time, looking up close, looking far, and the table on the next page will help you to review the IOL options. So first of all, we start with the single focus lenses. If you put one of these lenses in, you can either see only far or only near or only at intermediate range, and you need glasses for the rest, unless you do some level of blended vision. And these lenses, there's no additional charge for these lenses. Now the lenses on the right are what are called advanced technology lenses, and they cost between 500 and 1,000 euro more than a standard lens per lens. And these lenses can again be single focus, but this time correcting astigmatism. These lenses don't, but these lenses also correct astigmatism, or they can be lenses called increased range of focus. And they give you an increased range of focus, distance and intermediate, but not necessarily reading, but with a high quality of vision. or they can be a full range of focus. These give you the entire range of vision, but there will be a compromise in terms of the overall quality of vision and what night driving looks like. So the bottom line is there is no free lunch in optics. If you go for the very best vision, that's both eyes corrected to distance with a single focus lens, but you can't see anywhere else. You need glasses for up close. If you go with the best range of vision, you then land up with a very good range and you're free of glasses, but the quality of vision isn't quite as good as a single range focus lens. These are the most common lenses used at the clinic. The CLR monofocal IOL, which is a lens with single focus. The Acrosoft Panoptix trifocal IOL, or full range of vision. Or the Vivity IOL, which is a lens which gives you distance and intermediate. And in certain circumstances, you can have intermediate and near on the second eye, so giving you a very good range of vision with high quality vision. And then the toric lens, which corrects astigmatism. So monofocal standard lens provides only distance vision. And if you now need glasses for the rest of the range, an increased range of focus, like the Vivity lens, provides distance and intermediate. And a full range of focus, the trifocal, provides all three.
With a monofocal IOL, distance is clear, intermediate is blurred, up close is very blurred. When we use an increased range of focus IOL, like an EDOF, now intermediate is improved and both distance and intermediate are clear. Reading has improved, but is still not clear. And when we go to a full range of focus IOL, now all three distances are in focus. Right, so I'm going to show you what the various options mean. Let's say this is distance looking out the window over there. Intermediate is looking at the computer screen in front of us, and near is looking at your phone or a book. If you target both eyes at 0, what you're going to have is you're going to have distance vision without glasses for both eyes, but you're going to need glasses for the shaded area, so for intermediate and for near vision. If you do something like blended vision at 0 - 1, you'll have distance vision covered with one eye, you'll have computer vision covered with the other, but you're going to need glasses for reading. If you do 0 - 2, that's going to give you distance vision with one eye. There's going to be a gap for the computer screen. You'll have to come closer to it, but you'll have reading vision, so there'll be a gap over here. And this can be achieved with standard lenses, standard IOLs. If you decide you want to go with something a bit more, we can look at a trifocal. But the trifocal, you have these peaks of vision. There's a peak for distance, there's a peak for intermediate, there's a peak for near. So these targets are hit very well. You can see those well. But because of these troughs, you'll end up having halos around lights. And this disappears for most people, but for 3% of our patients tell us that they don't want to drive at night. When we ask them if they'd like to switch back to a lens like this, they say no, because they value the reading vision more and they don't drive much at night. So anyone who needs to drive a lot at night, we sort of avoid this. And then the last lens that we use a lot nowadays is an EDOF. We specifically use the Vivity lens because this has no glare and halos. And there are two choices there. The one is putting the lens in for distance in both eyes, and that automatically gives you distance and intermediate, but you need glasses up close. We very seldomly use it that way though. We normally use it as 0 - 0.75. And now what happens is you have distance and intermediate in the one eye, and in the second eye you have intermediate and near. The only difference here is on the odd occasion you may find you need glasses for some things up close, but there's no glare and halos. And the person who tells me that they're a taxi driver who wants to drive at night, but they want the best range of vision in order to see road signs, to see their dashboard, and to even see their phone to bill the passenger, that's their best choice. The person who says, I don't drive at night and I want the most complete range of vision, they go with the trifocal. So go and think about this, and we'll speak about it again when we do your final consent. Right. So once you've got to the place where you're saying, look, I want to try and get as much as I can. I want to get the best range of vision that I can. So that would be the trifocal, where you're getting distance, you're getting intermediate, you're getting near, but then you're also from these troughs, you're getting the glare and halos. So the best range is the trifocal. But the best quality of vision that extends the range is the vivity. And vivity gives you both distance and intermediate. So we know now that if you have vivity in your dominant eye, you'll end up seeing very well far and in between. And if you have the trifocal in your non-dominant eye, you tend not to get the glare and halos. So the way we make the decision is what's most important to you. If it's most important that you first of all see well at night, then the first thing to do is vivity in the first eye. And then by the time the second eye is done, you assess how much reading you get from this eye. Sometimes you get some reading from the vivity eye, and in that case you can put a vivity in the other eye, or you can offset the vivity just very, very slightly to give you a better range of vision, and you'll still have no glare and halos. Or what you do is you've got vivity in the first eye, but you didn't get much reading, then you add the trifocal to the second eye, and the trifocal gives you the reading you need. If you decide that the full range of vision is the most important, then you do the trifocal lens first in the non-dominant eye, and then before doing the second eye, you assess how much glare and halos you're getting from the trifocal. If the glare and halos you're getting is minimal, then you put a trifocal in the second eye, and you've now got a very good range of vision. It's exactly what you wanted, but you've mitigated the risk. If you find that the glare and halos from the trifocal is more than you want, then what you do in the second eye is place the vivity. And now with vivity in the one eye and a trifocal in the other, you've got both eyes seeing far, you've got both eyes seeing intermediate, you've got the trifocal seeing up close, but you've got vivity helping the near vision. So this combination gives you the best range of vision with the least amount of dysphotopsia or glare and halos. And the only reason you've got to think this through is to decide what's most important. Do I first want the very good vision and then assess how much reading I got? Or do I first want the full range and then assess how much glare I got? And that helps us decide what to do on the second eye.
Astigmatism is where the eye looks a bit like a rugby ball. And if you do correct astigmatism, you'll find that you have better vision without glasses, you have a better quality of vision, you have less eye strain, less inclined to fall and trip over things. And if you do require spectacles, they are lighter and cheaper. So with astigmatism, light coming into the eye is fixed on two different points, one here in front of the retina, one behind the retina, because the curvature on the front of the eye isn't round, but it's more oval. And you can get astigmatism where both points are in front of the retina, that's called myopic astigmatism, or where both points are behind the retina, that's called hyperopic astigmatism, or this case here, that's called mixed astigmatism, where one point is behind and one is in front. Now, toric lenses correct this.
When you have astigmatism, everything is blurry. And if you put in a monofocal IOL, you continue to have everything blurry, and you would require spectacles with cylinder correction to correct this. If you put in a toric monofocal IOL, the distance is clear, everything is better, but these are still tricky. And if you now put in a trifocal that is also correcting the astigmatism, you now have everything in focus.
All that remains now is for me to invite you to ask any questions that remain unanswered. Prior to having the surgery, ensure that all your questions have been satisfactorily answered, and do not proceed until you're comfortable with the consent and you feel that you've been adequately informed.